I do have Blue Cross. Can you get me a discount? Damn it. All right. Well, I get the honor of introducing Dr. Alan Peterson. Dr. Peterson is a board-certified clinical health psychologist. He's a professor and chief of Division of Behavioral Medicine at the University of Texas Health Science Center at San Antonio. He's the director of Strong Star Consortium, which includes over 150 research collaborators and 20 institutions worldwide. He served previously as the chair of the Department of Psychology and the director of clinical health psychology, postdoctoral fellowship programs at Wilford Hall. He's retired from the U.S. Air Force after 21 years of active duty. I think that probably deserves a round of applause just by itself. And he was deployed in support of Operation Noble Eagle, Enduring Freedom, Iraqi Freedom, and he has clinical and research experience in the areas of PTSD, psychological resilience, and military health psychology. He has over 300 scientific publications and presentations and has obtained over $100 million in peer-reviewed federal research funds. Can you get me a discount on my health insurance? Maybe you're the guy to ask. So without further ado, I will hand it over to Dr. Peterson. Thank you so much. Lovely to hear things are mine. Yeah.
Okay, great, thanks. Well, thanks for inviting me here today. Very excited to present, and one of the things I guess at this point I can kind of guarantee is when you're finished, you're going to be really, really hungry for lunch and knowledge, maybe. So was asked to talk today about things related to post-traumatic stress disorder. That's the area that I've worked in for a number of years now, and to kind of tailor the presentation towards the focus of this conference, which is the older individuals, aging individuals, and in particular aging veterans. So going to talk about PTSD in general, focus more specifically about PTSD in military veterans, and then highlight some things related to the aged veterans. I'm the director of what's called the Strong Star Consortium. This is kind of our wallpaper here, if you will. The middle piece there, that's our logo. All of the emblems from military branches as well as universities and other logos are the people that we collaborate with our work. I retired in 2005 from the military, so it's nice to be retired and kind of sailing into the sunset and kind of enjoying things. And I'm not sure how it happened, but now I have 3 jobs. So I'm at the UT Health Science Center, is the primary location where I'm at, but also a professor at UTSA, and then recently at the local San Antonio VA as well. Related to that, official disclosures, I don't have any financial arrangements or whatnot where I'm making any money related to my presentation here. Do have funding for the research through both the DoD and the VA, and because of my former military work and the VA work and whatnot, the things I'm saying here today, these are my opinions. I'm not representing the U.S. government or the military or the VA or whatnot. These are all my perspectives and opinions. So, overall, big picture, aging veterans over time can still have thoughts, things that bother them, whether it's months, years, or decades after they've served in a war zone. Many of them have PTSD that continues to go on. We have Vietnam veterans, Korea era veterans, even World War II veterans that may still have post-traumatic stress disorder or post-traumatic stress symptoms or things related to that many decades later. It's interesting to think about that. How was that possible? We've got lots of evidence-based interventions that have been developed. Why is it that individuals are still suffering from PTSD? We'll talk about that a little bit today. I think most of you probably are familiar with post-traumatic stress disorder or PTSD and the common symptoms that are there. So for the veterans, the standard types of symptoms would be nightmares. Hear about that a lot, and my guess is many of you have relatives that may be veterans. To begin with, I guess I should ask, how many of you in the audience actually are veterans yourself? Okay, so quite a few, all right. And my presumption is many of you have military family members or relatives and whatnot, and kind of a standard thing, especially for older veterans, would be we know they served, we know they did something, but I don't know exactly what it is because they never want to talk about it, right? Kind of a classic thing that's there. You may know or be aware from somebody that they have nightmares at times, and if you visit over the holidays, you may be aware that people have nightmares. They often avoid things, can become kind of isolated, so that's a classic symptom as well. Might be startled easily, kind of jumpy, may not really like the 4th of July, for example, and may not be as interested in things as they perhaps were in the past. So there's a number of reasons why PTSD symptoms may actually become worse later in life. So what we're finding right now is, despite the fact that there is many evidence-based interventions available for PTSD, if you look at Vietnam veterans, for example, you would assume that the numbers of Vietnam veterans with PTSD should be going down, but the reality is within the VA, the numbers are actually going up. So it's interesting. Why is it that the numbers would go up? You would think there would be less and less over time, but actually the numbers are increasing. Many individuals are retiring of retirement age, and they've been busy, they've been distracted, they've been able to focus on their jobs and their careers and their families and whatnot, and once they retire, they have time to think, and sometimes things start to bother them when they're of retirement age. Sometimes they start to have a number of medical problems. A number of medical comorbidities with PTSD is really quite high, especially in the older military veterans. And so as people feel less strong than they did in the past, suffering from a variety of medical problems, that adds to the problems with PTSD as well. Over the past 10, 12, 13 years, obviously there's been a lot of coverage of the wars in Iraq and Afghanistan. And for many of the older veterans, just the fact that another war has broken out after about 30 years and all of the coverage that's there, that gets a number of individuals ramped up. Our nation as a whole has really stepped up and tried not to repeat what happened after the Vietnam War, where the nation was kind of opposed to all of these individuals who actually were drafted, right? They were drafted to go, and yet based on a variety of factors, our nation kind of turned against many of our Vietnam veterans. So I think most of our Vietnam veterans are very pleased with the fact that the nation has not done that with the veterans of Iraq and Afghanistan. But the flip side of that is they're really annoyed and kind of angry at times that, to see all that's being given to them that was not necessarily given to the Vietnam veterans. So it adds to a little bit of irritation, although they're obviously very glad that we're not repeating that, what happened before. A number of veterans also, consume alcohol. I would say alcohol is probably the #1 self-management strategy for people that have PTSD, and especially for veterans. As people get older, sometimes, for a variety of reasons, people may decrease their alcohol consumption, and if they decrease their alcohol consumption, sometimes that makes the symptoms become more apparent as well. Other thing to think about is there may be a number of what we call trajectories with PTSD. Some people, when they serve in a war zone, will come back, they'll have symptoms right away. Sometimes people will not have symptoms right away, and the symptoms will become apparent months, years, sometimes even decades later, for some of the reasons that I just mentioned. And then there's a variety of other trajectories as well, where the symptoms may go up and down for a variety of reasons over time. So I want to today go through a variety of things, talk a little bit about what is PTSD, what are some of the factors we think are related to causing PTSD, what are some of the comorbidities. Going to try to put things in perspective for you today based on what's going on now, what has happened in the past, just to kind of bring the current conflicts in Iraq and Afghanistan in perspective related to some conflicts that have happened in the past. Want to talk a little about treatment, what kinds of things are available for the treatment of PTSD, and then talk a little bit about resources that are available. Helpful for me to know who the audience consists of today. So how many of you are physicians? Okay, got a few physicians. Nurses? About as many nurses. Allied health, psychologists, social workers, physical therapists, occupational therapists, okay. Medical administration types of people. Nobody there, they don't need their CEs, okay. Any other major groupings that I forgot about of individuals that you're not represented? Attorneys, okay, so people working in the legal area, okay. All right, very good, thanks. So again, PTSD, I think most people know about PTSD, about some of the common symptoms that are there. results from some type of a traumatic experience. So this is one of the disorders that's out there that doesn't exist in a vacuum. So if there's no trauma exposure, people don't develop non-trauma related post-traumatic stress disorder. So there has to be some type of a traumatic event. So compared to many disorders and diseases, there seems to be much less of the biological underpinnings that are causing the disorder, as opposed to a lot of other disorders that are out there. Right now, we're thinking about military conflict, thinking about people serving in the war zone. The reality is the primary cause of PTSD in America is motor vehicle accidents. If you think about today, before today is over, there will be some major accidents on 410, I-10, 1604, somewhere, 281. People will be significantly injured. There'll be some horrific injuries. Some people may die today. And that, in reality, is the primary cause of post-traumatic stress disorder. There's many other things related to assaults, natural disasters, and other potentially traumatic events that may be related to PTSD. We'll focus primarily on military veterans today, but keep in mind that there's many traumatic events that may lead to post-traumatic stress disorder. Again, I think the symptoms people are aware of: distressing memories, flashbacks that come up, memories of what happened during the traumatic event. Avoidance of trauma cues. There's some things that may cue a memory to the trauma. There's some things that may just feel dangerous or people feel uncomfortable. When people experience something like that, what do they naturally do if they're wanting to get better and cope? They leave the situation, and what happens? They feel better. So, many individuals that end up being isolated and avoiding things, it's kind of naturally reinforcing, if you will, because when people feel physically aroused or threatened or perceived danger, they leave it, they feel better. As long as they avoid those situations, they tend to do okay. So it's kind of naturally reinforcing for many individuals. There's many changes in mood that goes along with it, mood and cognitions, and then the hyper-arousal that takes place, right? So people that have an exaggerated startle may have difficulty concentrating, lots of sleep problems. How common is it? Overall, about 7% or so of Americans, adult Americans, have PTSD. More common in females than in males. And in military veterans, it's about twice that. So the number is about twice as high in those that have served in the military, especially those that have served in a combat zone. If you look at this is one of the largest studies that's been done, an epidemiological study. Basically see if I can not shut this off and get the laser on here. What this indicates is for men, about 61% of men at some point in their lives in America will experience a potentially traumatic event, an event that's significant enough that it could potentially cause something like PTSD. Out of those individuals that are exposed, it's only about 8% or so who at some point in their lives will meet the diagnostic criteria for PTSD. So lots of people are exposed, high percentage exposed. It's a much lower percentage that actually develop PTSD. For women, not as many are exposed. About half, 50% or so, are exposed to trauma, but about 20% are diagnosed with PTSD. So what is that all about? What does that mean? Basically, what that means is women don't have the coping resources, are not able to manage, are not quite as strong as men. Good. I'm glad that I got that reaction, because we'll talk about military veterans in a moment, and obviously that's not true, but we talk about military veterans, that same tendency to label individuals with PTSD as it being something related to weakness or a failure to cope or whatnot. It's really strong in the military veterans, and it's wrong, that belief is wrong for the same reason that it's wrong to say that about women. What is a more important piece? Type of trauma exposure. Right? The type of trauma exposure that occurs is really a significant factor. Not all trauma is the same. Some traumas, when they occur, make it likely, and some make it highly likely that people will develop post-traumatic stress disorder. So on the far right-hand side, for example, this indicates that less than 10%, or about less than 5% of the nation of adults in America will be a victim of rape at some point in their lives. Of that group, over 50% are likely to meet the diagnostic criteria for PTSD. And if you break that out for men and women, men are much more likely to be diagnosed with PTSD if they're a victim of rape. So males are even, again, the type of trauma makes a big difference. And you can see combat is a significant risk. There's other traumas where it's just the opposite. Natural disasters, a flood, a hurricane, or a tornado. Many of you, I grew up in Florida, so I went through lots of hurricanes. I never had one in which, there were bodies laying around and whatnot. So there's lots of people that have some type of trauma exposure, like a natural disaster, that don't develop PTSD from that. And if you add some things together, this is a study that looked at crime victims, and they broke them down into groups. So individuals on the far right, these were individuals who were a victim of rape. They were physically injured during the assault, and they also feared for their life. They thought that the assailant was going to kill them. If you add all those things together, about 80% of those individuals were diagnosed with PTSD. And similarly in the war zone, if you think about the kinds of things that may happen in a war zone, there's some events that take place that are so beyond belief, so horrible that the majority of people would likely develop PTSD after being exposed to that. The flip side is there's lots of, kind of like a natural disaster. In a war zone, again, I deployed 3 times myself, and the last deployment was in 2004, 2005 to Iraq, where I was at. Every day we had mortars and rockets that come in. So those are potentially traumatic events. They don't happen here very often, right? I worked in a very busy surgical hospital. In fact, while I was deployed to Balad, it was actually the busiest trauma hospital in the whole world. We had so many trauma cases coming through. So I probably had hundreds, if not thousands, of potentially traumatic events that I was exposed to. Many people there, the same thing. But most of those were things that we were trained for, we were prepared for, did okay with that. Sometimes it's these things that are beyond what anybody could imagine occurring. When those things occur, that's what people often struggle with. So again, things you anticipate, things you're trained for, most people do well with that, and that's why the majority of military personnel that deploy actually do well, are very resilient, come back, and are not suffering from PTSD. So who's at the greatest risk? Obviously, be the ones that are at the greatest risk for frequent trauma. When I think about the military people that I work with, I think about the tip of the spear people. Again, that may seem a little bit, you may not think about it that way, but the people that I see are individuals who have put themselves out there, got themselves more exposed, had more horrific things they were exposed to. Those are the individuals that are suffering from PTSD. It's not the individuals who are weak and have lack of coping resources and are not managing well. All of those factors are involved. If somebody has very poor social support, very poor unit cohesion, and lots of other lack of resources, they're obviously much more at risk. So those are factors, but the primary factor, the most important factor, are things related to the actual traumatic event itself. Someone who is at risk of a personal injury, which happens a lot in the war zone, exposed to death, and the bottom piece, which is what happens in the war zone a lot, people who experience things or see things that no humans should have to experience. Number one thing that has killed people, injured people, burns, amputations, PTSD, traumatic brain injury, are these explosions. These explosions take place. About 2/3 of all that have been killed and injured have been related to some type of a blast, primarily the improvised explosive devices, or the IEDs that you've heard of. When they occur, there can be significant damage. This is the back of the post-exchange. When I was deployed in Iraq, you can see if there's an IED or an explosion or a mortar that's nearby, it can do some significant damage to a concrete building. You can imagine what happens when there's a person that's nearby. If it's a tent, there's not much protection. Sometimes what happens in the war zone are long periods of extreme boredom followed by, extreme horror that happens very, very quickly. I was fortunate in my military career before 9/11, from 93 to 97, I happened to have an assignment in England at RAF Lakenheath in England with the Air Force, which was a great, great assignment. Really enjoyed it there. My wife and I go back on a regular basis. We happened to go back on the 65th anniversary of D-Day. And this was the headlines of the local paper. They interviewed a British military soldier who had survived on the beaches of Normandy, and basically in his interview what he said, there's not been a single day that's gone by in the past 65 years that he doesn't see those bodies floating in the water. I just gave you a quick glimpse of some of the images that people sometimes see in the war zone. And of course, that's, I'm sorry to do that, that's kind of disturbing, but it gives you an idea about some of the things that people see haunt them. They're difficult to get out of their head. This was not your trauma. You were not there. You didn't see these things. But even just this little image, my guess is if you close your eyes for a moment, some of those things that I flashed up for half a second, you can almost see some of those things in your head. So it gives you an idea. If you were actually there, heard the screaming, smelled the smells, all of the factors related to that, how some of those things are difficult for people to kind of get out of their heads. So again, thinking about older veterans, whether it's Vietnam or Korea or World War II, the things that people sometimes experience in the war zone are difficult for people to get out of their heads. Most of them are real pictures, not all of them. There's some that are, the middle one is actually, obviously that's a drawing. Some of these are from movies. The rest of them actually are real photos from World War II. All right, so before we get into the details of the older veterans, it's kind of helpful to get things into perspective. And I have some slides. You have copies of the slides. Like most presenters, this morning I went through and tried to update some of the figures and numbers that are there. So I've got a few slides that are a little bit different than what you have, but they're close. I went ahead and updated, in particular, the slides related to Afghanistan and Iraq and kind of separated them out. Basically, what I tried to do with this is, just looking at the major wars, major conflicts that have occurred in America over the past, 100 or 100 plus years. Civil War, my guess is many of you have traveled up into Maryland, Gettysburg, things like that, and you kind of hear what happened. It's like, oh my goodness, it's hard to believe what happened. So, Civil War, 625 Americans died during the Civil War. How many deaths per day? About 600 a day. It's just kind of hard to imagine that. And you can see the other numbers. World War II kind of going down, numbers going down. World War II actually was up from World War I. We get down to Iraq and Afghanistan. Fortunately, the numbers are much lower. So how many have died? This was updated just as of last night. So 2,300 in Afghanistan, about almost 4,500 in Iraq. And the numbers are, overall about one a day, maybe less than one a day in Afghanistan. So the numbers compared to sometimes in the past were really much lower. Another way to look at it is to look at looking at the population size. So if you look at the Civil War, for example, with a much smaller population, it was about 2%. So 2 out of every 100 people in the United States died during the Civil War. And you can see the numbers in the very bottom. The numbers are very, very low down there. Another way that epidemiologists like to look at it are the deaths per 100,000. And if you look at it that way, you can see the numbers as well. So back in the Civil War, almost 2,000 per 100,000, and about 1 or so per 100,000 of the population in Iraq and Afghanistan. So these are the deaths over time. And the surge was in 2007. I was actually deployed during this time, during 2004, and then the single month with the largest number of casualties was while I was deployed. I was deployed during the Battle of Fallujah, and that's still the single month, November of 2004, where there were the most injured, most killed at that point in time. We still have some folks, that's why I put the question mark there. We're kind of out of Iraq, but we're not out of Iraq, so I put a question mark there. So there was even one casualty, and we left in 2011. So 2010 was the end of what we call Operation Iraqi Freedom. The last year was called Operation New Dawn, when the official end of the conflict occurred during the last year of the troops being there, but even now there's still individuals that are at risk that are in Iraq, even if they're not in a combat role. Afghanistan, you can see the numbers have been much lower. They peaked later on, peaked in the 2010-2011 timeframe, and as of this week, about 46 have been killed in Afghanistan. Lethality has changed. In the current conflicts, it's about 10% or so that actually die of their wounds compared to a much higher percentage in the past. So about another way to kind of flip that over, 90%, actually more than 90% now, of individuals who are injured in the war zone actually survive. What that also means is that people that survive are individuals oftentimes that have the horrific injuries. When I was deployed right after 9/11 to Operation Enduring Freedom, we didn't go with any type of body armor. There were not up-armored vehicles. In fact, the IEDs that are very common now, they didn't exist at all for a long time. It was later on, as the wars went on, when they started doing the improvised explosive devices. When I deployed a few years later, 3 years later to Iraq, I deployed with body armor. So body armor will protect your vital organs, right? Your chest, your back. You have a Kevlar helmet that you'll wear. So people will survive a pretty significant injury, a blast injury, because of the personal protective gear that people wear. But the injuries they have, extremities, right? Arms, legs, face, can have some pretty significant injuries, but they may still survive of their wounds. When I was deployed, one of our young airmen walked out of his tent on 9/11, didn't think about it at the time, but 9/11/2004 actually was a very deadly day for us. One of our young airmen walked out of his tent, a mortar landed at his feet, took off both of his legs and one of his arms, and we had our Air Force medics and Air Force personnel to tie off tourniquets, and he is still the most seriously injured airman in history to have survived his wounds, because people were there immediately. He was in the hospital right away. So people can survive wounds that basically nobody else would have survived something like that. But these days, with the personal protective gear, with the advances in medicine, advances in medical evacuation to get people to locations, they're surviving at a much higher rate. But that also means that everybody along the way, there's much more trauma exposure that occurs, even in the medical personnel. We think medical people are trained for this, but even people that are surgeons and emergency room physicians and whatnot, the types of things you see in the war zone are way above and beyond oftentimes what you would see in a regular hospital. So even medics at times are exposed to things that can haunt them. So IEDs, about 2/3 of individuals who have been killed in the war zone have been related to IEDs across time. If you go back over time, even back to World War I, World War II, it's still explosive types of things have been the main cause of death, even though in the past there are many more gunshot wounds, for example, but blast injuries are historically a significant cause of death and injury. Signature injuries, people will argue, sometimes people say TBI, that's the signature injury, traumatic brain injury. Some would say PTSD. But there's also a significant number of amputations and significant number of burns. Here in San Antonio, we end up having the burn unit for the entire Department of Defense is here out at Fort Sam Houston. The same with the Center for the Intrepid. The amputee center is here. So many of the more seriously injured individuals end up being brought to San Antonio because of the medical center that's here. Recent numbers, the numbers vary if you look at who's at risk and what numbers exist for who has post-traumatic stress disorder. This is a military study that looked at a thing called the PDHA, the Post-Deployment Health Assessment. So it's a survey that's done of people when they're getting ready to come back from a deployment, and then the PDHRA is the reassessment. It's done 3 to 6 months later. So this just gives you an idea about what we think some of the risks are. So this would indicate that about 12% or so of active duty forces coming back from the war zone are at risk, we think are at risk for post-traumatic stress disorder. The numbers go up a little bit, 3 to 6 months later. And then for the Guard and the Reserves, the numbers are even higher. And we can talk about that later on, about what some of the reasons may be why the Guard and Reserves might be at more risk. And people are often asking, how do the rates of PTSD compare now to what they were like in the past? There's really no good systematic way to do it. You're kind of guessing when you do that. I provided those numbers, kind of a review of war in America, just to give you an idea about the numbers. And you have to imagine, if you were on the battlefield during the Civil War, or the beaches of Normandy or Iwo Jima or something like that, you just have to imagine that the amount of trauma exposure was much higher than it's been for our troops recently. But it's really hard to compare. The current war, the current conflict, we have people that are deployed 4, 5, 6 times. So the duration has been much longer, but the number of people that have been seriously injured and killed is much less. So it's really hard to really compare those things. If you do look at some of the older veterans, though, A survey that was done in the VA said that for older veterans, about 85% of them have had a significant traumatic event at some point. So again, it's the majority of people that have served in the military, the older veterans, have had some type of traumatic event. The lifetime prevalence of older veterans, when they've surveyed them looking at POWs of World War II and Korea, about 50% at some point had met criteria for PTSD. And out of those veterans, about 29% currently meet the criteria for PTSD. So it gives you an idea that, probably in the past there was even more trauma exposure than there has been recently. Part of the difference is we're aware right away. So we're now doing surveys, we're monitoring people, managing things, trying to provide resources as soon as possible. So part of why there's a big emphasis is we have knowledge now of what's going on, and we're trying to intervene early and not wait until later. At the end of the Vietnam War, there was not even the DSM, the Diagnostic and Statistical Manual didn't even have post-traumatic stress disorder in there. That didn't come in until 1980. So that's part of the problem as well as the diagnostic criteria. Even after the Vietnam War, it didn't even exist at that point. So it's hard to make sense out of those numbers. Lots of comorbidities, right? There's lots of things that go along with PTSD. It doesn't usually happen by itself. Depression is real common. Many of the things that cause PTSD also cause traumatic brain injuries. So it's common for people to have a concussion of some sort at the same time as some type of trauma exposure. Lots of problems with sleep, pain, substance use. I was on a DOD and VA committee a couple of years ago where we were looking at medication uses for post-traumatic stress disorder. We took an entire year's worth of individuals in the VA that were seen for a medical appointment where the primary diagnostic code was PTSD, and looked at the different medications that were being used. And right now, we'll talk in a moment, there's 2 FDA-approved medications, and the review of the database that we did, electronic database, there were 65 different medications that were given out for PTSD during one of those appointments. So obviously, there's a lot of off-label use of a variety of things. If you look at the comorbidities, depression, think of any medication you might give for depression, those are things that people may consider for PTSD. There's not a medication that's ever been developed specifically for PTSD. So think about depression, lots of depression medications people will give. Sleep disorders, that's lots of medications that may help people sleep. Those are considered for PTSD. Chronic pain is real common. Think of all the medications that might be used for chronic pain. So that's part of why there's this a challenge right now with what we call polypharmacy. The number one primary way that people treat PTSD in the VA, in the military, and the population as a whole is medications. That's the number one treatment that's used. I'm going to talk in a moment how that may not be the best thing right now and how we probably should consider some other things, but that's the reality of it. What's the impact? We've seen this in our older veterans. You think about Vietnam veterans, for example. Right now, about 13% of all of the adult homeless individuals in the United States are veterans. So it's a large percentage of individuals. Even around San Antonio, those of you that are from San Antonio, almost every day driving home, you'll see someone on a corner, and they say they're veterans. There's no way for us to tell whether they're really veterans or not, but obviously there's a high percentage of individuals who are homeless are veterans. Out of all of the homeless veterans that served in Iraq and Afghanistan, so about 2/3 of the veterans that served in Iraq and Afghanistan who are homeless, about 2/3 of them have got PTSD. So obviously it's a big risk factor for not being able to be employed, being homeless, avoidant, just not being able to fit in real well. Disability is a big piece as well. Average individual today who is discharged from active duty for a diagnosis of PTSD, the lifetime disability is estimated to be about $500,000. So it's very costly for our nation. Can it be treated effectively? Yes, it absolutely can be treated effectively. We have a lot to learn. In civilian studies, there's a couple of treatments called cognitive behavioral therapy treatments. There's 2 treatments that have been developed, and in civilian studies of primarily female assault victims, there's really strong data to say that 80% in one large study were treated into remission or treated below diagnostic threshold. A recent publication, 5-year follow-up, they were still in remission. So if you can imagine that, 80% of individuals doing really well with the treatment and then remaining well over time. You think about combat veterans, think about military veterans, there's been much less research. And the little research that's been done is primarily focused on Vietnam veterans, for example, and the treatments have not worked as well for a variety of reasons. So exactly how well these things will work is hard to say. How well they'll work with the combat-related PTSD and active duty military, and in particular, and in veterans, we don't have as much knowledge of that. Practice guidelines, there's a number of practice guidelines that are out there. The biggest one is the DoD VA clinical practice guideline. You can look it up online and get a free copy of it. It outlines two major types of treatments. One is the medications. There's 2 medications that are FDA approved. And then there's the other general category ends up being what we call cognitive behavioral therapies. These are talk therapies, talking about details related to the trauma. And there's a variety of treatments that fall into that category. In 2008, the Institute of Medicine did a very thorough scientific review of all of the published as well as unpublished data related to the treatment of PTSD, and their results were a little interesting. So basically their survey, and they really did a rigorous look at studies that were very well designed, very well powered, which ended up eliminating a number of studies. But basically, their review of the literature said the only type of treatment for post-traumatic stress disorder that has sufficient evidence to support its efficacy are exposure-based therapies, so exposure-based cognitive behavioral therapy. So this talk therapy, which basically means there's a variety of ways of talking about what happened. And that's the last thing people want to do that have been exposed to trauma, is talk about what happened. But that's part of the problem, is if they're not talking about it, years later it's going to continue to fester. They're going to have nightmares. So at some point, there needs to be something, some details about what happened, and talking about those details. The more that that's done, the more you can kind of put some of those memories to rest, if you will. There's a variety of other counseling types of therapies that are used. There's many, many kinds that are out there. The Institute of Medicine said at this point there's not sufficient evidence for their efficacy. And the most controversial one was this last piece. The Institute of Medicine said at this point there's really no evidence that any medications of any kind, actually work. I mean, how is that possible? There's 2 FDA-approved medications. I don't understand that, right? How can it be that the Institute of Medicine says these medications don't work? This is one of the studies that led to FDA approval for paroxetine, and basically this indicates at the baseline both the active medication group and the placebo group, everybody had PTSD to start with. At the end of 12 weeks of medication or placebo, you can see the difference, and you can see there was a placebo effect as well. But the difference between these two, which is about 15% difference or so between the groups, was statistically significant and gives you an idea about how this medication led to FDA approval. Since then, there's been many studies that have been done, but 2 large studies. One was by Matt Friedman, who just retired as the director of the National Center for PTSD, so arguably the most important psychiatrist in charge of the National Center for PTSD, the largest randomized clinical trial ever done looking at medications in the VA setting. And basically, the results were no significant difference on the blinded diagnostic measure between one of the FDA-approved medications and the placebo. Another study was done by John Crystal, who is at Yale University and the director of the Neurosciences Division of the National Center for PTSD, looked at using of risperidone in addition to other medications for PTSD, 300 people in the study. The same thing. It was no difference than the placebo that's there. So I'm saying that because that's the most common way that people are managed. My assumption is many of you're doing your best to manage with a medication. Maybe there's some other things above and beyond that would be something to consider, especially in the aging veterans. So 2 of the therapies, one's called prolonged exposure, one's called cognitive processing therapy. Not going to get into a lot of details of those today, but these 2 treatments are treatments that the VA has decided that every VA hospital in the nation is mandated to have counselors, have therapists that are trained in these 2 therapies. So these are the 2 that have the strongest evidence. It's still kind of controversial. This exposure therapy piece, people sometimes think it's cruel. Somebody's already been traumatized, and now you're going to have them focus on the details of what happened. They might become upset. They might cry. or they might blubber or something like that. Sometimes that happens. You can talk with people. I've talked with people 40, 50 years after the trauma, and if they've pushed it away, locked it away in the back of their head, when they finally tell someone the details that they've never told anyone in their life, it's like it happened yesterday. But the more they do that, fairly quickly, people can really get much better and can, never totally put the memory to rest, but get to the point where they can think about the memory and it doesn't trigger off a reaction just like it happened yesterday. So both of these treatments are available at all of the VA hospitals. The prolonged exposure is the one that actually has the most scientific data to support it. It's also the one that's most controversial because it's this exposure piece. Again, talking about what happened. The analogy I many times give is imagine that you're a counselor somewhere and you're seeing a mom that comes in whose 8-year-old child was playing in the street and got run over by a truck and killed. Right? Horrible, horrible accident. If you were the counselor and the mother came in, what would you do? You probably would want to talk about what happened, right? And probably that mother or father, doesn't matter who you're saying, probably if you talk with them about that, they probably would become upset. They probably would cry. They probably would wail. And what would you think? Would you think, oh my goodness, I'm making this person worse? No, you would be thinking, this is a horrible, horrible thing that happened, and it's important for us to talk about this and figure out how to make sense out of life and figure out a way to move forward, right? So in that scenario, you think if you talk with someone about trauma, they may become upset, but that's okay. You're trying to work with them and help sort through that and move forward. But for some reason, when we think about veterans, especially military veterans, to bring them into an office and talk about what happened, they might get upset. People think that's kind of cruel treatment, which is it's just interesting. So I'm saying that because you'll hear from clinicians, you'll hear from veterans that they get fearful of talking about what happened. Many veterans would rather go into the war zone, rather risk their lives again than to talk about what happened. Why? Because they're so fearful of it. They're fearful that they're going to break down, they're going to cry, something's going to happen. But it does anyways. It happens in the middle of the night when they're dreaming, they have nightmares. When they least want it to occur, the symptoms come out and they have to run out of a room, run out of a restaurant, leave a family event. And so it comes out at the least wanted times. In a counselor's office, with nobody around, if a person gets upset, that's okay. That's part of the process. You can help people get better with that. So this is an example of the study I talked about a moment ago. So in this study, these were female sexual assault victims. So it's not combat veterans, so we can't generalize that we're going to get the same results with combat veterans. But in this study, again, 100% had PTSD at the start of treatment, the 2 different types of therapies. At the end of treatment, and then they just published a 5-year follow-up, only 20% still have PTSD. So 80% of people, I'm not an oncologist, but if I was an oncologist and 5 years later, people no longer, at the end of treatment, people no longer had symptoms, and 5 years later, they were still in remission. If I were an oncologist, I might use the C word for that, right? We don't tend to say, cured, but many patients would argue that they feel like they're cured from PTSD when they're 5 years later and they're managing really well. I don't think we need to bother whether we call it that or not, but obviously there are some treatments like the 2 that the VA has rolled out that have a lot of potential there. Another study was done recently that's a little bit different. So this is a study that looked at early interventions. It was a study done in Israel and took people within the first month after they were exposed to trauma and looked at medications, looked at these 2 types of counseling that I talked about to see whether you can intervene early and maybe actually prevent PTSD by talking to people within the first month or so. So in this study, had about 300 people. Most, as I mentioned, in this case, 76% were motor vehicle accidents. So most were motor vehicle accidents. It's an interesting design for a study. It's called equipoise stratified randomization, which basically means there's 4 arms of the study. People are given informed consent. Here's this counseling, here's the risk and benefits, here's this other version, here's the medications, these are the risk and benefits. People can say, that's fine, I'm willing to be randomized to all 4 arms of the study, or if there's one they don't like that exposure therapy thing, if they say, that sounds terrifying, I'm not going to do that, they can say, I don't want that one, and then they get randomized in the other 3, or they can eliminate up to 2. So if they eliminate up to 2, The last two arms that are left, they get randomized to those. So it's an interesting way to do a randomized study, but also allow patient choice to say, I'll take any of those four, or I want to eliminate one or two. End results of the study, what did people decline more than anything else? They declined the medication. So it's interesting. If you ask the patients, if you give them informed consent, here's the risk and benefits of the medications versus exposure therapy versus cognitive therapy and others, that's what they tended to decline more than anything else. And there's few numbers of others that they declined. Overall, the majority of people ended up getting this exposure therapy. So more received that treatment. Why? That means that was the one that was least likely to be declined or deferred or not chosen by individuals, or not eliminated, rather. End results were those that got the counselings on the left-hand side there. This indicated at the 5-month follow-up, so 5 months later, followed up to see which individuals actually went on to develop PTSD. Once again, only about 20% that got these two versions of counseling developed PTSD. Those that got the medication or the placebo or the wait list, there was no difference between those. About 60% of them went on to meet criteria for PTSD. So early interventions, doing versions of talking with people are likely to prevent PTSD as well, which is interesting. And then a different version would be individuals who have done really well over time and may not have had PTSD. Maybe they did, but it wasn't diagnosed. But there's another term that's sometimes used called late onset stress symptomatology. So these would be older veterans that you may be seeing that, again, they've stopped working. They may be decreasing their alcohol consumption. They may have a lot of other factors, and now all of a sudden they're kind of having some significant stress types of symptoms. They may or may not meet the criteria for PTSD, but there's a population, we call them late onset stress symptomatology, or sometimes referred to as LAWS. So they're at a point of their lives where they may start to think back more about their wartime experiences. They may be more emotional related to that, and we don't know exactly the best forms of treatment or whatnot for that. We think probably some of those counseling types of things, even supportive counseling, may be helpful. We think it is kind of normal for veterans when they get of a certain age to be thinking back on their wartime experiences. Maybe that's the time for them to try to sort through things, think through things, try to make sense out of their lives. And that's what many individuals do when we're reaching our older ages, is to be looking back on life, trying to make sense out of the meaning of life. So it's something to think about with the older veterans. So resources, the number one resource we always think about for veterans would be the VA. There's controversy related to the VA, right? There's been concerns about not being able to get in time and whatnot. That being said, it's the largest organization that has the highest trained individuals that exist related to helping our older veterans with PTSD. So that's always a good resource. The National Center for PTSD has many resources online to educate veterans, to educate providers, to educate family members on what kinds of options may be available. The reality is many of our veterans actually are seeking care in the community, especially the individuals who are the Guard and reserves that end up going to remote locations all around our nation. There may not be a VA nearby, and there's a large percentage of veterans actually are not even eligible for the VA. And so there's individuals you may see in your practice or whatnot that may have PTSD, may need treatment, and they may not be eligible in the VA. So the VA is a good resource. The National Center for PTSD has lots of information there as well. The program that I have is really focused more on younger veterans. It's called Strong Star, and it's here in San Antonio at the UT Health Science Center. That's our logo, and our motto is Building Strong, Resilient Warriors. Basically, we've been funded by the Department of Defense to do the largest randomized trials, the first ones to be done with active duty military. So we're doing studies here in San Antonio, studies up at Fort Hood. We're trying to test out some of these treatments that have been shown to be effective in civilian PTSD victims, but have never been tested out of the military. So we have large studies that are going on. Many of our studies are actually going on up at Fort Hood right now, and we're about to finish them in the late fall. Basically, our primary focus is developing and evaluating evidence-based treatments for combat-related PTSD in active duty veterans or recently discharged veterans. So focusing more on the younger individuals, but our research is informed by research that was done in civilian populations and to some extent in veteran populations, and our research will go back not only for the active duty, but to inform the treatment of older veterans as well as civilians. Most recently, we got a kind of a follow-on, if you will, for Strong Star, and it's called the Consortium to Alleviate PTSD. We're just getting that consortium started. And similarly, we'll be doing research, kind of developing and evaluating treatments. We'll be looking more at the neuroscience and biomarkers that are related to post-traumatic stress disorder with some of these studies. Do have a website there as well that has information. If you have veterans locally, we do have some studies in which even older veterans are eligible for. There's no cost for our studies. Most of our studies are focused on treatment. We have a study we've just started that's looking at the cognitive processing therapy. Actually, we have 3 arms to that study. One arm is face-to-face in the office, and because of the stigma and the concerns about going in for care, this study actually offers one arm, which is you give the same therapy through telebehavioral health to the patient's home. So patients don't even have to come into the clinic. They can log onto their computer with a secure hookup, and we'll deliver the entire treatment through telebehavioral health. And then the third arm of the study, so we can compare all aspects, is face-to-face in the patient's home. So actually we'll send our therapist to the patient's home and deliver the care. So individuals that are injured, may be bedridden, may, for physical and psychological reasons, not be able to leave their home, we can deliver care either through a computer or potentially send someone to the house. So you worry about getting the full dose of therapy. If some of you may be home health nurses or may have done that work before, if you bring the care to the individual, they're much more likely to get the care that they need. If you wait for them to come in, sometimes they don't come in. And some of the concerns in the military and the VA are the wait list and whatnot that exist. We're trying to look at other other ways of being able to deliver care that meet the patient's needs. So kind of to summarize, all of us potentially have something that we can do to help us kind of solve the puzzle of PTSD, to do things to help our veterans to manage with PTSD, to get effective treatments, and especially for the older veterans, in which for most of them they've gone for many, many years and may not have ever been diagnosed, or when they were diagnosed there may not have been some of the treatments that are available now, so that they may have gone for decades and decades not realizing that there are some things that might potentially be helpful for them. So there may be resources for the older veterans that are available that they've either never been offered or that they've never considered. Thanks. We got about 10 minutes.
Sentirme un poquito